You may have noticed lately I have been interested in these issues regarding right to die, medical aid in dying, death with dignity. I'm trying not to, bore you to death with it, but, when lightning strikes here, right? My father passed away recently. I had spoken to 3 members of the Final Exit Network about, right to die issues, not just in the United States, but in countries all around the world. And they had turned me onto a book by Katie Engelhart called The Inevitable. And it was a fascinating book. And it was so well written. And I thought, wouldn't it be great to get Katie on the broadcast to talk about this very thing, to talk about her experiences in the writing of The Inevitable. Katie joins us today. Hi, thanks for coming.
Thank you for having me.
So your background is in, history and philosophy, but you jumped into, would you call yourself an investigative reporter? I mean, give me your kind of background and focus these days.
I don't know where the border is where one gets to call oneself an investigative reporter versus just a normal journalist. But I studied history and philosophy in graduate school, thought about getting a PhD, left that behind, and I've been a reporter ever since.
The Inevitable is not really an activist book. It doesn't read like one. It's really interesting how dispassionate's not the word. I don't know if we can be totally objective, but you managed to really remove yourself to the point where you were the observer more than the advocate one way or the other. And this was like a purposeful approach to these right to die issues, right?
Yeah, it was I think initially it was very purposeful. I very much wanted to write this book from the perspective of just a journalist. I didn't want to be an activist. I feel like the conversation has been dominated by activists and by medical providers, and I didn't want to do that. So that was my strategy. But actually, it was much easier than I thought it would be, because as I reported the book, I found things are much more complicated than I'd originally imagined. And in fact, this is really one area where I felt more uncertain after 5 years of reporting on some parts of this discussion than I was at the beginning. So it was actually easy to maintain this neutral position, or sort of a position of skepticism and detachment, as you say.
Why this subject, though? Do you have a death fascination? Are you a morbid person, Katie? I mean, why this subject? Why now?
I mean, I think I've thought about death and been interested in death and talked to my family about death and dying from a young age. But the sort of unglamorous start to this story was just that I was living in London. I was working for a news outlet that assigned me to a story on medical aid in dying. The British government was debating whether or not to pass a bill. It was pretty clear from the start that, 80% of the British public wanted the bill to pass. It wasn't going to pass. And I kind of followed this debate, and it's the same debate we've seen everywhere else, where physician-assisted death is up for legal discussion. On the one hand, people are arguing that this is a really important thing for patient autonomy and a way for patients to access dignity at the end of their lives. On the other hand, critics warn that there would be this slippery slope, and soon we'd be marching vulnerable people to deaths. So I found the subject interesting, but also, it was predictable. And as I reported deeper, I just learned that there was so much going on beyond the legal world and the medical world. People were really struggling to find solutions on their own. And I didn't feel like people were talking about that. I didn't feel like there was a lot of honest conversation about this. And so that led me on this 5-year saga.
So you're based in Canada. What do these discussions look like across the northern border of the USA? I mean, what is a right to die conversation? What do the laws look like in Canada right now?
Funny enough, for Canada, I guess, Canada's emerged as this complete radical when it comes to right to die issues. So while medical aid in dying has been legal in places like Oregon for a quarter of a century, it was not legal in Canada until several years ago when the government passed a federal law allowing people who with certain qualifying criteria to access physician-assisted death. Since then, in just a few years, the law has expanded. So, in the United States, where it's legal, someone only qualifies if he is terminally ill and has 6 months or left to live. This means that most people who do physician-assisted death in the United States are really within days or weeks of what we could call a natural death. So it's really just shortening life by a small amount of time. In Canada, the criteria is much broader. So someone doesn't have to be near the end of his life. And he needs only to be suffering seriously and in a way that he finds to be unbearable. And in 2023, the Canadian law will open to people who are physically well, but who are suffering from a mental illness. So presumably people with refractory depression, PTSD, those sorts of conditions might qualify for the law.
And that sort of bleeds us back into the slippery slope questions. What happens if somebody just says, I'm unhappy, I want to kill myself, and I would like, a physician-assisted option or some sort of a formal process to die? Do we let sad people just pull the plug whenever there may be something going on that needs to be addressed otherwise? Perhaps it can be fixed. I don't know that I know the answer. Like, I'm a proponent of medical aid in dying, bodily autonomy, especially after seeing my father pass, right? He had pulmonary fibrosis. Essentially, the man suffocates to death. And I thought to myself, what would I do? And I came to the conclusion quickly that I don't want to go that far.
Yeah.
This whole, it's God's decision. He'll take me when he's ready. For me, it was like, no, I don't want to go through the days, weeks, months of that kind of suffering. But if I was suffering from depression, that's a medical diagnosis. I don't know. It's a tough conversation. How do you navigate that in your own skull, Katie?
Well, first of all, the slippery slope argument, it's an interesting thing to think about. And I think it's one of these areas where I don't think any side is particularly honest. So, activists who promote medical aid in dying in the United States will say the slippery slope is absolutely not real. Once these laws pass, they remain very limited. And that has been true, but only in the American context. Everywhere else, there has been an expansion of criteria. Places like Belgium and the Netherlands and Canada, the law starts out narrow and eventually it includes more kinds of suffering. So I think, again, to be kind of honest about this, we should acknowledge that these laws tend to expand outside of the United States. But mental illness is a very tricky one. I mean, right now, someone who's just sad in a place like Belgium won't qualify. There needs to be evidence that the person has suffered for a long time, has tried a number of treatments, and psychiatrists usually want to come to a conclusion that that person is incurable. Now, there's no clear test for incurable mental disorders, and we know that some people do recover after long periods of illness. So that's sort of untidy. These laws also require that someone be suffering unbearably, but only an individual can decide whether pain is unbearable. So that's also subjective. I talked to a lot of psychiatrists in Canada who are really debating this question of, touching on what you said, where do we draw the line? How much do we require, for instance, that a patient have tried? Does a patient with persistent depression need to have tried X number of medications, 3 kinds of treatment approaches, and this many sessions of psychotherapy? Like, do we draw that kind of clear line, or do we make it more up to the patient himself? It's a difficult question, and again, it's this area where we treat physical and mental illness is very different.
Even though we're talking about an illness of the brain, which is an organ, so
exactly.
This mental illness really is physical illness.
Yeah. If you have cancer, it's very much within your rights to say, I don't want chemotherapy. I'd rather just go home, spend the time with my family, feel good for as long as I can. Or, it would be kind of not uncommon for your doctor to say, we've tried X number of rounds of chemotherapy. This is not going to work for you. Another round would just be futile. And unfortunately, we're going to have to switch you to palliative care. But that doesn't tend to happen in the same way with mental illnesses. First of all, it's, we don't like the idea of someone just saying, well, no thanks, I won't try this treatment. This is my right to not try. And likewise, it's not as common for a psychiatrist to say, well, you've been suffering from refractory depression for X number of years. It's just unlikely you're going to get better. So let's move to some other kind of treatment that's not aiming for a cure.
I think it leans a little bit into other bodily autonomy discussions. We talk about female reproductive choice, et cetera. It resonates with me. It's my life. It's none of your goddamn business what I do or what I don't do, or if I'm going to pull the plug early, just keep out and let me do what I'm going to do. I do tend to I sympathize with that attitude. And I think that attitude has merit. I don't know. Do you have an opinion about that? Like, it's my life. There's an old Richard Dreyfuss film about the right to die called Whose Life Is It Anyway? Like, what would you say to that? Whose life is it anyway? Well, it's mine.
Yeah. And actually, I found that a lot of people who I interviewed, people who, aren't particularly well-versed in medical law or end-of-life healthcare, they're actually surprised and quite indignant when they find out that they don't really have that much control, that it's not within their powers to just say, no, I want to go now. I think people sort of assume that because they have that kind of bodily control earlier in life, they would have it at the end too, and they don't. There's an activist I write about in my book who has this line that I think about all the time. He says, life is a gift, but you're allowed to throw away gifts. And if you can't throw it away, then it's a burden. So, I do think that's true. But again, these laws are strange because, what we have in effect is the government's deciding on sort of almost philosophical, existential medical criteria for when a person is allowed to die, deserves an easy death. And that's sort of an awkward arrangement.
This is a show that often tackles criticisms of religion. I don't know what your position is on religion. I don't really care for this conversation, right? That's not what we're talking about. But I do want to speak about high control religions who do want to mandate the life and death choices of other people. And in your book, in your research, you have to have sort of smashed into this reality. We see these high control religious institutions who are saying, well, it's not that I say that you can't do it, but God says that you can't do it. Can you speak to that at all?
Yeah, all of the major religions are against medical aid in dying. And there have even been sort of, recently there was like a consortium of leaders of different faiths, Judaism, Islam, Christianity, who kind of got together to oppose these policies. It's particularly relevant in the United States because the Catholic Church controls so much of American healthcare. It's something like 1 out of 5 or 1 out of 6 acute hospital beds in the United States are in Catholic institutions. A lot of hospices are Catholic run. So that's disruptive. But I even see, I think, particularly Catholic philosophy being, coming up actually through doctors. So doctors who don't necessarily identify as religious will say to me something like, well, I've helped a lot of patients at the end of life. And I think there's just something important about that transition period. And maybe there is some suffering and some pain, but, it leads to something greater, some sort of realization or some sort of, that's Catholic thinking, right? That there's some redemption in that kind of suffering. I think the question is whether we ought to make someone suffer because we think it's good for them.
Mother Teresa used to be the same way, right? God finds How did she say it? There is joy in our suffering, or suffering in this life brings bliss in the next, kind of thing,
Yeah.
which is, if
Yeah.
you're looking at solving human problems and reducing suffering here on this sort of real world with our feet planted on the ground, it's a tragic way of looking at suffering because it seems to allow people or even celebrate their suffering. So,
Yeah. I think it almost sets people up for disappointment. I mean, I think it plays into this very romantic view of what a deathbed looks like. And that's just not really based on reality. So if we're looking at an American state where aid in dying is legal, again, people are usually shortening their lives by weeks or, days. And, often these deaths are medicalized. Someone's in a medical facility. There's a lot of drugs involved. I mean, there aren't necessarily the person who's dying isn't necessarily capable of having, these moments of philosophical insight or these deep moments with family where, old battles are hashed out and worked through. I mean, often the person's kind of in and out of sedation, and if they're elderly, there's some degree of dementia that's settled in, and actually, I think this idea of deathbed redemption or clarity can make people feel let down by what the deaths they see actually look like, because they're not always cathartic or special. They're often slow and confusing and yeah, very much medicalized.
it's certainly not what we see in the movies. They're lying back and
Yeah.
you see them begin to glaze over, but they're still lucid
Yeah.
enough to be able to say,
Yeah.
"Tell the children I love
Yeah.
them." And then the music plays and they close their eyes,
Yeah.
and it's this sort of punctuation mark that's perfectly timed. That's just not the
Yeah.
real world. Yeah.
But funny enough, a medical aid in dying, like a physician-assisted death, sometimes does look like that because it has been choreographed and has been planned. So I watched a death. I watched a man, an 89-year-old man with prostate cancer, have his life ended by his physician. And, he was probably within a week or two of dying naturally. So he was already starting to have some moments with less lucidity. But because he had scheduled this death with his doctor, his 3 kids from 3 different states were able to fly in to California. They were all literally sitting on his bed, touching him while he died. He knew roughly when he was going to lose consciousness from these drugs. And so he could say what he wanted to say. The last thing he said was, he turned to his daughter and he said, "You're the most wonderful girl I ever knew." It was sort of that movie death.
I
But
mean, the
only
difference was,
because,
though, I like the word choreograph. It wasn't
yeah,
like, he'd been, suffocating or, up to his eyeballs in morphine or
yeah,
in the kind of pain that causes you to, hallucinate, that kind of thing. I mean,
yeah,
he really had a chance to sort of take hold of
yeah,
it. And I think that's probably what we always come back to, like on my terms, while I can still think and act for myself kind of thing. Your book, The Inevitable Dispatches on the Right to Die, is not a book of legal bullet points, although there's a lot of data in there about what the law says and which states allow or don't allow in many of the discussions. The Supreme Court, all that's in there. But yours is more a book of anecdotes, which I love because I really feel like the human story is what this is about. Without reading the book to me, give me some examples. I mean, some of the stories that you encountered that resonated the most with you.
yeah. So I followed a number of individuals, really 6 for this book, and in some cases was meeting with them on and off for many years, and so got to know them and their lives quite well. A woman I think about often, her name was Avril Henry. She was a professor in Exeter, England, where I was living in England at the time that I met her, and she was, she had this really interesting life. She was a professor of art history and early modern history. She owned a beautiful house with a beautiful garden, was known as an entertainer, a real free spirit. She loved art so much. She would weep when she saw certain colors and hues. Just really had a very vibrant life. And she was in her 80s, and there was nothing in particular that was killing her. She didn't have any terminal disease or cancer, though she wished she did have cancer. She was envious of people who had cancer. She just simply felt like the kind of everyday challenges of aging had become unbearable. So things like deafness, she had some neuropathy in her feet, limited mobility. She was losing control of her bladder and bowels, which was very uncomfortable. And she just decided that she didn't want to grow very old. She was as old as she wanted to be. And she ended up taking her life to avoid, further progression into old age. What William also called it the cold gradations of decay. That's what she was hoping to avoid. But she had a sort of traumatic final month. She had hooked up with some activists who instructed her on how to order a lethal barbiturate online. And by the way, this is like, I met numerous 80-year-olds who taught themselves how to use encrypted email and, ended up buying drugs from some black market dealer in China or Mexico. She was able to do this, but the police did catch wise and try to intervene with her death. So she was able to end her own life, but really with the power of the state and the British healthcare system fighting against her and trying to stop her, and sort of confused by her. At one point she was, authorities entered her home and social workers were brought in and a psychiatrist, and she was subject to this wellness test. And there was this real sense of they wanted to come to the conclusion that she was just, ill, mentally ill, and needed to be saved. And the conclusion they came to instead was just she was completely, she was acting rationally. She had complete capacity. She was completely lucid. And there was really nothing they could do. And that clearly confused legal and medical authorities.
Let me, just a couple of points of clarification. When you said that she wished she had cancer, meaning that she wished she had something that would expedite the end, or at least she wouldn't have to excuse her reasons or feel the need to excuse her reasons for wanting to die early. In that way, she would have preferred a cancer or some sort of an overwhelming diagnosis that pointed more clearly to an end. Is that accurate? Yeah,
that's right. She felt, and she was correct that she might have been able to live for quite a long time with what she had.
Which gets us into the are you living or just existing kind of conversation, right? If everything else is deteriorating. It was interesting in your book how you talked about, you mentioned this network of encrypted emails and how clever people have felt that, they need to become. A lot of people would go to their physicians, get medications, some kind of barbiturate may not be the word I'm looking for, but instead of taking them month to month, day to day, they would stockpile them. They would keep them and they would end up amassing this, this overdosing amount of it, preparing for that day. And there's like a whole, I guess, do we call it an underground of people who they're just sort of socking away the pills, right?
People do. I think it's harder now. I think we have this image that there are all these wink, wink, nudge, nudge arrangements between, elderly people and their doctors. And I'm sure that occurs in some situations, but, it's hard for doctors to be prescribing these kinds of drugs without being found out. Also, just medicines are a lot safer than they used to be. So, barbiturates used to be prescribed as sleeping pills, and someone could hoard those, but that doesn't happen anymore. And I think also we have to think about who would have access to that kind of information. It would be like a certain sort of educated person who knows something, who's taught herself something about pharmacology, or maybe has the trust of her doctor. There's a lot of people who just wouldn't get to benefit from those sort of arrangements. But yes, I did meet, I met, and I didn't actually write about her in the book, but I met a few times with a woman who has multiple sclerosis in her, I believe, 70s. And she had been offered a kind of medication that she didn't think she needed because she didn't really have the symptoms. But then she read online that it was lethal in large doses, and so went back to her doctor and said, actually, I would like some of that. The problem there is that, we don't know much about how people die when they die this way. Overdosing on drugs can be painful and messy and slow. And, I think it's sort of heartbreaking, the idea of someone dying alone in that way.
Or getting it wrong. I mean, what happens if the suicide fails? I mean, not just pills. We've seen people's gunshots who survive, perhaps in a vegetative state, which leans us back into another reason that we would advocate for at least having a medical professional involved to supervise to make sure that something horrible doesn't sort of come out of it. And that's a whole other thing. I don't want to digress there just a second. Without being morbid, though, can you give me some specific examples of the methods people use, legal or otherwise, in these scenarios to end their lives? You mentioned the barbiturate, but in your reporting and your research, what did you find people are doing?
Yeah, I wrote about this activist named Dr. Philip Nitschke. He was a medical doctor. He actually lost his medical license in the course of my reporting because he was offering what he calls DIY death seminars. So he goes around. Often his meetings are in Unitarian churches. That's, I guess, I should clarify, that's the one religious community that's sort of chill about right to die issues. And so he'll rent out a Unitarian church, a Universalist Unitarian church, and have a meeting with people, many of them with white hair, and he'll teach them about different drugs and drug combinations. But some people find a way to get barbiturates. I opened my book with the story of a lawyer on the Upper West Side who is in her late 70s and who traveled to Mexico to buy barbiturates from a pet store, a Mexican pet store. Pet stores in places like Mexico and Brazil have been known to sell the drugs more liberally. Like these are euthanasia drugs for animals. And then some people find ways to do gas asphyxiation. That is common because it's apparently painless. At the very end of my book, I write about a very, very strange conference I attended, which brings together kind of right to die, like the main players in the right to die fringe, I want to say. So kind of like activists and scientists, but also just very interested people who are tinkerers, and they try to come up with solutions, ways for people to die that are, they say, quick and painless and that are available. So using different kind of household equipment or substances.
I was talking to the Final Exit Network. They use the inert gas, and I think there's a hose that goes to a hood.
Yeah. Mm-hmm.
I mean, it is what it is. But if I visualize this, I don't know, Katie, does it seem culty? I mean, I don't think it's culty. Like, it's a method, and it's free, and it's, I mean, it's a way to sort of pull the plug on your terms. So it's not that I'm opposed to it, but the visual of it is striking. Someone lies back, they've got a tank and a hose and a plastic bag taped around their neck.
Bag.
I mean, do you have an opinion or have perspective on, I mean, how did that make you feel?
I did follow one woman who had dementia who did die that way. And for her, it was a solution that seemed acceptable because it didn't require her to break the law. She'd never broken the law. She wasn't a rule breaker by definition. And, it's not illegal to get pure gas canister and, in her case, a turkey bag for roasting turkeys over Thanksgiving and a bit of plastic hose. This is something she could do fairly, without having to be in secret. Yeah, the aesthetic is really ugly, and I think in some cases, family members are going to have to come across that, and I imagine that would be very difficult for them. But I think what activists are trying to do is disabuse people of the idea that they can swallow a bottle of Tylenol and end their life quickly and painlessly. I mean, that probably won't work, and damage will probably be caused in the meantime. I get sort of anxious, and I was certainly very anxious when I was writing about this stuff because, I didn't want to be accused of providing a how-to guide. But there are how-to guides out there. And I think this is another weird aspect of this debate where journalists are really afraid of writing about this. Publications are really, really afraid of, no one who reviewed my book names the substances that I name in it. And I get that impulse. However, we're in 2021. Any information that someone wants to access is readily available online. I didn't meet anyone who was finding anything new from a New York Times article. They'd done their research and they knew what they needed to know.
Sorry about that. Didn't mean to interrupt you, but I was wondering if this is like, from your perspective, more of an America-centric phobia. Is it here? I mean, are there other I know we talk about European nations and whatnot that seem to have more of a libertarian sort of a view of it.
Yeah. Well, I think in terms of the talking about it, I mean, I think it gets very complicated because people are very anxious about reporting on suicide in general. And some of that is due to a fear that reporting on suicide will lead to copycat suicides. Now, we can pick apart that science, and I think there's some good evidence that a lot of the fear of the copycat suicide phenomenon is sort of like hysterical and not totally factual, or not totally relevant in the internet age where things are already out there. But that anxiety translates to how we report on physician-assisted death, or what used to be called physician-assisted suicide. It feels to editors or journalists like sort of like suicide, so maybe it's this verboten topic, but it's also kind of not, because we've acknowledged that these other people's suicide is a different kind of suicide. It's one that's based more on reason. So I just think there's a lot of fear, and the result of that fear is just silence because it's easier.
I think right to die advocates also are trying to change the language. Instead of saying commit suicide, it's to die by suicide, because commit sort of implies a crime or something untoward.
Right.
I mean, that was your experience?
Attempt, successful suicide. But I mean, right to die activists, right to die proponents they don't want the word suicide at all. Their argument is that, a physician-assisted death is something different, and that patients who choose it don't identify with, suicide. I don't know that that's fully true. I think there are plenty of people who used the word suicide with me and felt comfortable with it, but certainly proponents prefer a more medicalized language.
How are you doing for time? I have a few more questions I'd like
to
throw out.
Fire away.
Dr. Jack Kevorkian. I came out of a religious background, and we thought the guy was nuts. And he may have been nuts. I don't know. But, Dr. Jack Kevorkian, for those who may not be familiar with his story, who was an American pathologist who gained fame back in, I think, the late 70s, throughout the 80s, and into the early 90s, as I understand it, for being a fierce advocate for, I think euthanasia would be the word I would use, or physician-assisted suicide, and the guy was very flamboyant and outlandish, and he ended up, I think, doing prison time for his the last one that he'd been involved with, which I think took place in the back of a van, like he had a VW van, and he put the patient in there. Your journey has included the story of Jack Kevorkian. I'll just throw it out there and you can take it wherever you wish. Dr. Kevorkian, what are your thoughts?
Well, I think that anyone in the movement today would describe Kevorkian as, an important, like a game changer, of course, because he brought this issue to the attention of Americans, but also a very imperfect flag bearer for the cause. I mean, beyond the fact that he was very weird. I mean, he was like a pathologist who had never really practiced medicine and used to paint with his own blood. I mean, he was kind of like a ghoulish, freaky guy. He was very, he wasn't careful, I should say that. So he was operating by his own criteria, and they weren't very strict. And in some cases, I think it's pretty clear that the people he helped to die weren't in a very serious state, weren't very far along in their diseases, and that he invented this kind of machine that would allow people to press a button and pull a lever or whatever and have lethal substances injected into them. He did go to jail in the end because he committed a straight up euthanasia. So he injected a patient himself. But the public supported him also. And I think, his first patient was a woman with dementia. And I think that really struck a lot of people who were seeing dementia become more prevalent and who were scared. And here was this one person offering a way out of it. But certainly proponents of medical aid in dying today want nothing to do with Kevorkian.
I can imagine. I mean, he was so eccentric, so eclectic, so off the chain or off the charts that, I can imagine they were thinking, this is not the poster boy for these serious discussions that we need.
No. Yeah. No, and also in a way, like a part of Kevorkian's thinking was very traditional, which upsets activists in a different way. So he really saw himself as this gatekeeper. He had the medical training, he had the medical knowledge, and he would decide who deserved these deaths. And he believed that doctors should be involved and mediating the process. And now, of course, there are activists who think doctors shouldn't be involved, that they don't deserve this gatekeeper role, that actually the science of life ending is not terribly complicated, and that there would be ways to take it out of doctors' hands.
And this speaks probably to something that resonates with you since you have a background in philosophy. What constitutes doing no harm, right? The Hippocratic Oath is doing no harm, not involving the medical profession in assisting someone with an earlier death or watching suffering. Is that harm? So helping them exit would be the act of mercy and medical aids, right? I mean, this is I don't know, it's slippery slope's not the word, but it sure is messy when we talk about this stuff.
Yeah, it's messy. I think you're right. A lot of doctors have interpreted do no harm as don't be involved in life ending, but do doctors have an obligation to prevent future harm, prevent future pain and suffering that they're able to predict with reasonable certainty? But I think there's also this point that I tried to think through in the book, which is, right now we have medical criteria for assisted death. So again, in the United States, you got to be terminally ill. You have to be within 6 months of a natural death, according to 2 doctors. But what we know from the data that we have from states like Oregon is that people are choosing to die for reasons that are more existential. So they want to preserve what they would call dignity or autonomy, or they want to die before they lose the ability to do things that are enjoyable. And so I think it's fair to ask why we have doctors mediating a process that isn't purely medical. I mean, no one's choosing to die strictly because of this tumor. It's always like a tumor in context of a life, and it's complicated and messy. And so our checklist is actually quite looking at just like a narrow aspect of that choice.
Talking about messy, you mentioned that one of the criteria, at least in states where it is allowed, you got to have a couple of doctors say you got 6 months or less. Mm-hmm. Hugely subjective analysis or diagnosis. Yeah. So the human body is so complicated. Circumstances are so unique. I mean, it's not totally arbitrary. I mean, obviously they're gauging it based on, their scans, the CTs, the MRIs, the blood work, et cetera. But I mean, who really knows? It could be 6 months, could be 2 years, right?
Yeah. Yeah. And I think doctors are comfortable with 6 months because it's also the cutoff for hospice. So it's like it exists already in the healthcare system. But you're right, doctors are in general really bad at predicting these outcomes. And there's some studies that show that if doctors are like close to a patient, have treated a patient for a long time, they're more likely to get it wrong just because, they're kind of rooting for their patients. Often patients who are young, we see like their doctors will push more care on them, even when it's kind of clear that the treatment is futile because they kind of don't want to give up on this young person, and that can cause suffering. But yeah, it is fairly subjective. But again, what we find in the states where it's legal is, people want to live. So doctors haven't found that someone's qualifies, you've got 6 months, and they march into their doctor's office, ready to go, ready for their lethal cocktail. In fact, people wait until the end, and often they wait too long. So most states have something like a 10-day waiting period. And sometimes patients actually wait so long that after their first assessment, they either die on their own or they lose mental capacity. So they lose the ability to consent.
Which brings us to, I think, an extremely important part of this conversation. And again, I'm speaking with Katie Engelhart. She is author of the book, The Inevitable: Dispatches on the Right to Die. Just having the option for some people is really what they need to perhaps find the joy in continuing. Like just knowing, look, at least I have control over it. It's there. Many people who realize it's there, they don't decide to pull the plug right off the bat. In fact, some of these people thought, I think I might try it for another few weeks, months, or years, right?
Yeah, I think it's something like a third of people in some states never take it. And so doctors have suggested to me that the drugs themselves are a kind of palliative cure. It just makes people feel better once they have the prescription in hand. And I did hear stories of patients who were able to, at least in the interpretation of their doctors and families, enjoy life more at the end because they knew that if it got unbearable, they could end it. And some people just actually found that the natural death was fine, that the kind of slow move towards death wasn't as painful and bad as they expected it to be, and they didn't need to or didn't want to take action on their own.
You mentioned that you had befriended some of these people. It's inevitable, right? If you're interviewing them, you're following their stories over these long periods of time. You're a human being. You had a heart connection to some of these people. You had to have, right? And then you're there at the last moment when they draw their last breath. So how does that balance work? Katie, the objective reporter who's compiling the data, and the person who made a new friend who was watching the last seconds of their life. What's happening in your skull when you're in the room?
Yeah, I guess I probably wouldn't use the word friend, but you're right. There is, of course, there's a closeness that develops if I'm becoming so intimate with someone's life over the course of a few years. And for some people, I felt like, I kind of had access to their thoughts on the level that a therapist might, but I'd also interviewed their family and their colleagues and, maybe read their journals. And I just had this incredibly close view on their personalities. And yeah, of course, that led to closeness. But I did, I was very careful. First of all, I thought these people all deserved sort of the same level of professionalism that any other subject would get from me for any other story. But also, I was very wary of influencing the course of events. I'm not, I don't believe in purely objective journalism. I don't believe it exists. I know that as soon as I'm there in a room, I'm influencing things. But I tried to minimize that impact. So in every case, I was very clear with someone that even if we were developing this relationship, they weren't obligated to me in any way. They could stop talking to me. They could stop answering my phone calls. They could decide they didn't want their story to be part of the book, and that was fine. And I would respect that choice. I also made it clear to them that I wasn't invested in any particular ending. One man said to me of his daughter, he said, it was something like, I'm paraphrasing, but it was almost exactly like, I don't want her to die to give you a good ending for your book. And I'm worried that there might be pressure for her to do that. And could only say I agree that it seems like there could be pressure, and I hope that there's not.
So, I mean, if you're in the room, they're surrounded by the people they've invited, right? They've got parents and children and siblings and neighbors and friends and coworkers.
Yeah.
How do they look at you? Are they raising the eyebrow?
I was only present for one death in this book. The others, I had different levels of proximity with. So in a few cases, I knew, in the case of the woman I mentioned who had dementia, I spoke to her a couple of hours before she died for an hour and knew exactly when she was going to go and in what circumstance and, how she would be found and all of that. But I wasn't actually there. And that was for a number of reasons: preference of the person and how they wanted to die, protecting myself. Again, not, making it clear that I trying to minimize my impact. But yeah, in almost every case, I did speak to a person's family members or friends or colleagues or medical providers or all of the above. And there were mixed reactions. I had, some people were very open to speaking with me and really saw it as a way of supporting the person they loved. And some people were incredibly wary. One woman's father agreed to speak with me only after kind of 2 years of me trying and with a lot of hesitation. A few family members spoke to me and then, wanted to redact their interviews and just didn't want to be dragged into it. So I think people were very apprehensive of what my take was going to be and how I was going to spin the story of their loved one's life.
I was thinking if, my time came and I decided this is the day and I'd invited those I cared most about, I would wonder in my mind, are they there thinking, good for him, he's leaving in his own terms, or are they thinking, this is horrible and tragic and there's nothing I can do about it? I'm sure the opinion spectrum varied. People who maybe came but extremely reluctantly wishing they had done something else. You saw any of that?
Yeah, I think it's natural for people to feel like a person's death wish reflects a failure on their part to somehow make their lives okay. And I think there's a lot of guilt that's wrapped up with that. The one death I did watch, it was actually the opposite. I think shortly after, or perhaps even while the man was dying, but unconscious, his son said, "I wish we'd done this sooner," because he felt like actually his father had suffered a lot over the previous few weeks and would have wanted to die sooner. So I think there were a lot of mixed feelings. And I think, going back to that woman who was very elderly and just didn't want to grow older, she had friends who had the reaction of like, well, you're not that bad. You go swimming every day. You drive to the swimming pool and you swim. Like, how bad can you be? And I think that's also very natural. And her point was kind of like, I'm bad enough. I decide. Yeah. It's not like if I can go swimming, my life has meaning.
So you don't have to answer these next two questions, but I debated even asking them. But okay, I'll throw them out and you can accept or decline, okay? You're sitting in the room. I couldn't help in my mind researching this stuff to think, well, how would I want mine to play out? Like, who would I invite? And would there be music? And what songs would I choose? And would it be in my home? And what room would I be in? And, did you do any of that in your own skull? Like, what if? What would it look like? What would my decisions be?
Yeah, I think people expect me to have a much better answer to this. But the truth is, I might be a cling on till the bitter end person. I think it's very possible, that I would be the type of person who just wants to try for as long as possible. My sister's a doctor and we joke a little bit. I'll say like, my end of life wishes, and she'll say, yep, I got it. Desperate measures. But also who knows? I think, I'm lucky enough not to be in terrible, terrible persistent pain. And I have seen the effect the toll that takes on someone. I think that I've had the opportunity to talk a lot more with people in my life about what they want. And I think there are a fair number of people I know for whom like control at the end is the most important. And this is also like something we're going to see a lot with the boomer generation, is just they seize control of their lives in ways that were new, and they won't want to relinquish that control at the very end.
I guess that answers my second question, which I debated even asking. You're a reporter, you're a journalist, you're trying to be objective. But I'm thinking the whole time, how do you feel about this? Are you an advocate of medical aid in dying? I mean, in your personal life, beyond the profession, beyond the reporting, beyond the documentation of these moments, where do you fall on this? So, I'll throw it out and you can answer or skip it.
Yeah, well, I kind of get it this in the conclusion, but I think it's fairly easy for me to support, for instance, the kind of law that exists in American states where we're talking about people who are terminally ill and near their deaths. I mean, these are not philosophically radical laws, though they provoke, an enormous response. I mean, we're talking about someone ending their lives by a couple of days or weeks to avoid pain or kind of delirium in most cases. But then I do have the sense that those laws are also quite imperfect, because they do privilege certain kinds of pain over others. So for instance, someone with very severe multiple sclerosis that a patient finds unbearable wouldn't qualify, because a doctor wouldn't be able to say, you're within 6 months of natural death. I mean, that person's likely to decline over a long period of time and then die from, aspiration pneumonia or any number of things that could come and swoop in suddenly. And I think it would make sense for a law to take those people into account. And then, I think then things get complicated. So when we're thinking of things like advanced age and mental illness, I don't think there's a perfect answer. And I think it wouldn't be legislated, carried out perfectly anyway. But I do have this sense that the American laws are a little bit too narrow in their interpretation of suffering. I mean, I think, it's important to remember that even in places where it's been legal for many, many years, it's very rare. Most people want to live for as long as they can. That's just what most people want to do. And most people aren't going to choose this when it's an option. So I think we don't need to worry too much about this becoming the way that people die.
Like, we don't necessarily need to jump into the worst case scenarios of these sort of star chamber death panels, sending people off into the desert to die, kind of.
It just hasn't played out. I mean, even in a place like the Netherlands, where it's, it's very popular law, and we're talking about like something like 4% of overall deaths, which is still a very small number.
Making it even harder with it being so imperfect and complicated and messy is that we live in the world where people want a cut and dry A, B, black, white binary answer. They want it to fit in a cookie cutter, and they want it fast, and they want it to be over with. And nuance makes this even more difficult. It's a beautiful book. It's beautifully written. It's well communicated. I don't know, Katie, I'm a fan. It's the reason I've been
Thank you.
pinging your email and pestering you and saying, I would love to have you on the show, because it's, it's a compassionate book, but it's dispassionate enough in the important ways that it doesn't come off like you're pounding a drum or waving a placard. You are the observer on an extremely complicated series of issues related to death, which is something that affects all of us. And I just want to tell my viewers, it's a beautiful book. I actually have the Kindle and the audio version, so I listen to your voice on my walks as you were personally accounting many of these anecdotes, and it's just moving and important stuff. Thank you for talking to me today, and I'll put a link to the book in the description box in the hopes that people will take the journey on their own, okay?
I hope so too, and people can contact me through my website if they have something to say about it.
KatieEngelhart.com. It's been a joy. Thanks so much.
Thank you so much.